Today we will review Dandy-Walker syndrome through the updated literature review by Ocampo-Navia and colleagues. The central message is that Dandy-Walker syndrome is best understood as a developmental spectrum of posterior fossa abnormalities. Diagnosis depends on anatomy: the cerebellar vermes, the fourth ventricle, the posterior fossa cyst, choroid plexus position, and the pattern of hydrocephalus. Prognosis and treatment depend not only on those findings, but also on associated central nervous system, systemic, and genetic anomalies. The review considers Dandy-Walker syndrome to be a heterogeneous group of midline cerebellar developmental disorders. The estimated incidence is about 1 in 25,000 to 1 in 35,000 live births. Hydrocephalus is present in roughly 80% of Dandy-Walker malformation or syndrome cases, and Dandy-Walker syndrome accounts for an estimated 4 to 12% of pediatric hydrocephalus. But hydrocephalus is not, by itself, a defining criterion for Dandy-Walker malformation. Treatment is often directed at cerebrospinal fluid dynamics, while diagnosis requires careful anatomical pattern recognition. The terminology around Dandy-Walker syndrome has evolved over more than a century. Sutton described related posterior fossa cystic pathology in the late 19th century. Dandy and Blackfin later reported hydrocephalus, an enlarged posterior fossa, vermian agenesis, and cystic fourth ventricular dilation. Walker further characterized congenital foraminal occlusion and hydrocephalus, and Benda introduced the term Dandy-Walker malformation in 1954. The review emphasizes that modern practice should avoid the older term Dandy-Walker variant. It is too nonspecific, and it can obscure important distinctions among inferior vermian hypoplasia, Blake's pouch cyst, megacisterna magna, and neurogenetic conditions with prominent retrocerebellar cerebrospinal fluid spaces. Classic Dandy-Walker malformation involves a posterior fossa cyst that communicates widely with the fourth ventricle. Along with inferior vermian agenesis or hypoplasia, rotation and upward displacement of the vermes, flattening or loss of the fastigial angle, and displacement of the cerebellar hemispheres. Blake's pouch cyst is different. It is an inferior and posterior cystic collection, usually with a normal vermes and cerebellum, and without free midline communication with the surrounding subarachnoid space. Megacisterna magna is different again. It is a retro or infracerebellar cerebrospinal fluid space greater than 10 mm on midsagittal imaging, with an intact vermes, a normal fourth ventricle, free communication, and no hydrocephalus. In practice, the question is, what does the cyst communicate with, and what has happened to the vermes and fourth ventricle? Etiology is also heterogeneous. Dandy-Walker syndrome is a developmental disorder influenced by multiple genetic, chromosomal, environmental, and epigenetic factors. Chromosomal abnormalities are frequently discussed in the literature, and recurrent loci include 3q24 and 6p25. 3. The genes ZIC1 and ZIC4 are implicated in cerebellar development, and FOXC1 is associated with chromosome 6p25-related Dandy-Walker malformation. Environmental factors such as maternal alcohol exposure, gestational diabetes, and infections during pregnancy are also cited. The clinical implication is that no single cause explains all cases, so evaluation should be individualized. The embryology explains the development of the syndrome. Around the fourth week of gestation, the cranial neuropore closes and the primary brain vesicles form, including the rhomencephalon or hindbrain. The rhomencephalon then divides into the metencephalon, which gives rise to the cerebellum and pons, and the myelencephalon, which gives rise to the medulla. The fourth ventricle forms from the neural canal in this region, while the roof plate widens and thins. By the sixth week, the rhombic lips thicken along the lateral edges of the roof plate. By about the ninth week, they contribute to the cerebellar hemispheres and vermes through midline fusion. This is why malformations of the vermes, fourth ventricular roof, and posterior fossa cerebrospinal fluid spaces are developmentally linked. The second embryology step is especially important. Around the 10th week, the choroid plexus precursor presses into the roof plate of the fourth ventricle. This creates the plica choroidalis, which divides the roof plate into an anterior membranous area or anterior membranous area and a posterior membranous area or posterior membranous area. The posterior membranous area fills with cerebrospinal fluid to form Blake's pouch. Later, Blake's pouch becomes permeable, creating the median foramen of Magendie. The review uses this model to explain two failure points. Failure of anterior membranous area integration with the choroid plexus can generate Dandy-Walker malformation. while failure of posterior membranous area regression or fenestration can generate Blake's pouch cyst. Those embryological failure points map directly onto the clinical radiological entities. In Dandy-Walker malformation, anterior membranous area integration failure produces a large posterior cyst, upward rotation or displacement of the vermis, and variable hydrocephalus. In Blake's pouch cyst, posterior membranous area regression or fenestration failure produces an inferior and posterior cyst, and tetraventricular hydrocephalus can occur. In megacisterna magna, the vermis remains intact, the fourth ventricle is normal, cerebrospinal fluid communicates freely, and hydrocephalus is absent. So embryology is the guide to diagnosis. Clinical presentation depends on the anatomical subtype, severity, associated malformations, and age at diagnosis. Many cases are detected prenatally, especially when ultrasound identifies a posterior fossa abnormality. In infancy, hydrocephalus often drives the presentation, with progressive head circumference, macrocephaly, bulging fontanelle, suture diastases, scalp venous distension, setting sun sign, or upward gaze palsy. In older children, once fontanelles have closed, symptoms may resemble a posterior fossa mass, ataxia, nystagmus, spasticity, and impaired fine motor control. Mild anomalies can occasionally present later in adolescence or adulthood, including with cognitive or psychiatric manifestations. Associated malformations are one of the most important parts of the review. Postnatal studies report associated anomalies in approximately 50 to 70% of cases. These may include central nervous system anomalies such as ventriculomegaly, holoprosencephaly, encephalocele, or agenesis of the corpus callosum. They may also include cardiovascular, urogenital, intestinal, craniofacial, and limb anomalies, as well as genetic or syndromic diagnoses. The overall outcome is not determined by the posterior fossa cyst alone. Survival and neurodevelopmental prognosis worsen as the number and severity of affected organ systems increase. Prenatal diagnosis usually begins with ultrasound. The review cautions that diagnosis should generally be made from the 18th week onward, because the cerebellar vermis may still be incompletely developed before about 17 to 18 weeks. That timing is important to avoid false positives. Imaging should include both axial and mid-sagittal planes. The examiner should assess vermian morphology, vertical diameter, fissures, fastigium, tentorium and torcula position, cyst communication, and choroid plexus position. Angles can help. After 20 weeks, a brainstem vermis angle greater than 45 degrees suggests Dandy-Walker malformation, while an angle below 30 degrees favors Blake's pouch cyst. Fetal MRI is useful when ultrasound is limited or when detailed anatomy and associated anomalies need clarification. After birth, MRI provides the most detailed anatomical characterization. Several classic postnatal MRI features have been described: hypoplasia, anterior rotation and superior displacement of the remaining vermis, agenesis of the inferior vermis, a large posterior fossa cyst communicating with the fourth ventricle, upward displacement of the tentorium and torcula, and anterolateral displacement of the cerebellar hemispheres. If hydrocephalus is present, supratentorial ventriculomegaly may be prominent. The sagittal plane is especially useful for vermian and tentorial relationships, while the axial plane helps show cerebellar hemispheric displacement and ventricular size. The review also emphasizes that diagnostic criteria have shifted. Posterior fossa enlargement and high torcular position should not be treated as primary diagnostic criteria by themselves, because they may reflect the degree of fourth ventricular outflow obstruction rather than the malformation. The more contemporary imaging definition focuses on inferior vermian hypoplasia, an unpaired caudal lobule, obtuse fastigial recess, large tegmentovermian angle, and displacement of the teniatella choroidea complex and choroid plexus. A useful distinction is that Dandy-Walker malformation tends to have a flat or obtuse fastigial angle, whereas vermian hypoplasia tends to preserve an acute fastigial angle. The differential diagnosis includes inferior vermian hypoplasia, posterior fossa arachnoid cyst, cerebellar hypoplasia, panventriculomegaly with a wide foramen of Magendie and large cisterna magna, and neurogenetic disorders with prominent retrocerebellar cerebrospinal fluid spaces. The discriminators are anatomical. Is the vermis intact, hypoplastic, dysplastic, or partially absent? Is the fastigial angle acute or obtuse? Does the cyst communicate with the fourth ventricle or the subarachnoid space? Where is the choroid plexus? Is hydrocephalus present, and if so, is it tetraventricular, supratentorial, absent, or disproportionate? These details prevent diagnostic lumping. Treatment is not aimed at reversing the primary congenital malformation. The goal is to manage symptomatic hydrocephalus, posterior fossa cyst expansion, and pressure imbalance between compartments. Options discussed in the review include cyst membrane fenestration or excision, cystoperitoneal shunting, ventriculoperitoneal shunting, cyst ventriculoperitoneal shunting, and endoscopic third ventriculostomy, with or without choroid plexus cauterization. Associated anomalies require parallel multidisciplinary management because treating cerebrospinal fluid dynamics alone does not address the full prognosis. Procedure choice should be individualized. Ventriculoperitoneal shunting is technically familiar and may have lower risks of malposition or migration, but there are concerns about ascending transtentorial herniation or acquired aqueductal stenosis in selected anatomy. Cystoperitoneal shunting may decompress the posterior fossa compartment first, but posterior fossa subdural collections have been reported. Combined cyst ventriculoperitoneal shunts can equalize supra- and infratentorial compartments, although they may alter aqueductal flow. Endoscopic third ventriculostomy is attractive because it avoids an implanted foreign body and may be more physiological when the aqueduct is patent and the third ventricular and cyst anatomy are favorable. The review's practical recommendation is high-resolution preoperative imaging of posterior fossa architecture and aqueductal patency before choosing the first procedure. Prognosis spans a wide range. At the favorable end, partial Vermean agenesis with otherwise intact brain architecture may be compatible with near-normal life. At the adverse end, severe Vermean dysplasia with midline brain anomalies and multisystem congenital defects is associated with poorer survival, intellectual outcome, and neurological development. Counseling should therefore separate isolated or mild posterior fossa findings from syndromic or multisystem disease. Follow-up priorities include serial head growth, hydrocephalus surveillance, developmental assessment, early therapy, evaluation of associated anomalies, and genetics or multidisciplinary care when syndromic features are present. A practical workflow follows naturally from the review. First, detect the abnormality, usually by prenatal ultrasound or postnatal imaging. Second, define the anatomy, Vermes, fastigium, tegmentovermean or brainstem Vermes angle, cyst communication, choroid plexus position, aqueduct, and ventricles. Third, search widely for supratentorial central nervous system anomalies, systemic malformations, and genetic or syndromic clues. Fourth, if the patient is symptomatic or hydrocephalus is present, treat the cerebrospinal fluid problem using the strategy that best matches the compartment anatomy. Finally, follow long-term for development, shunt, or endoscopic third ventriculostomy durability, head growth, and the burden of associated anomalies. The review's strengths are its contemporary terminology, its embryology-first explanation, and its clinically practical discussion of prenatal diagnosis, MRI criteria, and operative strategy. Its limits are also important. It is an updated literature review rather than a systematic review or meta-analysis, so it is not designed to quantify pooled outcomes or compare treatments definitively. Much of the treatment literature remains retrospective, and terminology remains inconsistent across historical and radiological sources. Important open questions include which imaging biomarkers best predict endoscopic third ventriculostomy success, how genetic findings should be integrated into prenatal counseling, and whether standardized nomenclature can improve outcome reporting. The take-home message is that Dandy-Walker syndrome is a spectrum, not a single lesion. Embryology explains why the Vermes, fourth ventricle, Blake's pouch, and posterior fossa cerebrospinal fluid spaces are linked. Diagnosis requires pattern recognition rather than reliance on one feature, such as a large posterior fossa. Treatment targets hydrocephalus and cyst dynamics, with procedure choice guided by compartment anatomy and aqueductal patency. Finally, prognosis is driven largely by associated central nervous system, systemic, and genetic anomalies. Accurate anatomy, broad anomaly assessment, and individualized management are the core of modern Dandy-Walker care.